Hello class, welcome to Chapter 7, Airway Management. We're going to be going through the National EMS Education Standard competencies involving airway management, respiration, and artificial ventilation. This applies the knowledge or fundamental depth and foundational breadth of general anatomy and physiology to assure a patent airway, adequate mechanical ventilation, and respiration while awaiting additional EMS response for patients of all ages. We will be talking about airway management at the practice level of the EMR, and we'll be covering or touching upon in this lecture airway anatomy, which is covered in pages 108 and 109 of your textbook, airway assessment, which is covered on page 111 of your textbook, and the techniques of ensuring a patent airway, which are on pages 111 through 114 of your textbook. And we'll also be talking about respiration, which is specifically the anatomy of the respiratory system, which is covered on pages 108 through 110 of your text. We'll also be discussing the physiology and pathophysiology of respiration, covered in pages 108 through 110. Pulmonary ventilation, which is on pages 108 and 109 of your text. Oxygenation, covered on pages 108 through 110 of your text. Respiration, covered on pages 108 through 110. External, which is pages 108 through 110. Internal aspects of respiration, covered on pages 108 through 110 of your text. And cellular respiration, covered on pages 108 through 110 of your text. These standard competencies will also include the assessment and management of adequate and inadequate respiration, covered on page 119, supplemental oxygen therapy, covered on pages 132 through 134 of your text, and we'll be discussing artificial ventilation, which is the assessment and management of adequate and inadequate ventilation, specifically artificial ventilation, covered on pages 119 through 127 of your text. We will be covering minute ventilation, covered on pages 108 and 109 in your book, alveolar ventilation, covered also on pages 108 and 109, and the effect of artificial ventilation on cardiac output on pages 108 and 109 in your text. We'll also be talking about pathophysiology, which uses the simple knowledge of shock and respiratory compromise to respond to life threats. When we're talking about medicine specifically here, what we mean is the ability to recognize and manage life threats based on assessment findings of a patient with a medical emergency while awaiting additional emergency response. And the last part of these standard competencies we'll be covering involving the respiratory system are the anatomy, signs, symptoms, and the management of respiratory emergencies, including those that affect the upper airway, which is covered on pages 119 through 132 of your text, and the lower airway, also covered on pages 119 through 132 of your text. This chapter introduces the two most important life-saving skills, those involving airway care and rescue breathing. Patients must have an open airway and must maintain adequate breathing to survive. By using simple skills, you can often literally make the difference between life and death. The ABCs of life-saving skills are airway, breathing, and circulation. And we'll be talking about, and you must remember, the check and correct processes for both airway and breathing skills. To maintain life, all humans must have food, water, and oxygen. Lack of oxygen, even for a few minutes, can result in irreversible damage and death, not just to brain, but also vital organs. If brain cells are deprived of oxygen and nutrients for as little as 4 to 6 minutes, they begin to die. Brain death is followed by death of the entire organism or the entire body. The main purpose of respiratory system is to provide oxygen and remove carbon dioxide from red blood cells as they pass through the lungs. This is figure 7-1 from your textbook, and it shows the anatomy of the respiratory system and the parts of the body specifically used in breathing. The first of these is the mouth, or the oropharynx, and the second is the nose, which is the nasopharynx. And it's very important that you remember these correct medical terms. And the easy way to remember them is the oropharynx, or the mouth. The mouth is the oral opening. So if you remember that, you'll remember that the mouth is the oropharynx. The nose, the nasopharynx, if you think about your nose or nasal passages, that will help you remember the proper term, nasopharynx. Also involved in the anatomy and function of the respiratory system are the throat, the trachea, which is the windpipe, the lungs, the diaphragm, which is the dome-shaped muscle between the chest and the abdomen, and there are several chest muscles also involved. Those muscles between the ribs, those are called the intercostal muscles, etc. In an unconscious patient who's lying on his or her back, the passage of air through both the nose and mouth may be blocked by the tongue. People who are unconscious have complete lack of muscle control, so the tongue will relax into the back of the throat and obstruct the airway, including the air that's able to enter through the nose or the mouth. So when someone who's unconscious and has no muscle tone, the tongue will relax into the back of the throat and block the airway as a whole. The tongue is attached to the lower jaw or the mandible, and if an airway is partially blocked, that will produce a snoring sound. There are other parts of the respiratory system that you need to be aware of as well. At the back of the throat are two passages: the esophagus, which is the tube through which food passes to the stomach, and the trachea, which is the airway or windpipe that goes directly into the lungs. The epiglottis is a thin flapper valve that allows air to enter the trachea but helps prevent food or water from entering the airway. Below the trachea, the airway divides into two bronchi. These are two large tubes supported by cartilage. If you refer back to your diagram, you'll see the bronchi clearly illustrated. The lungs are located on either side of the heart and are protected by the sternum or the chest plate at the front of the body and by the rib cage at the sides and the back. Smaller airways that branch from the bronchi are called the bronchioles. The bronchioles end as tiny air sacs called alveoli. The actual exchange of gases, of oxygen and carbon dioxide, takes place across a thin membrane that separates capillaries of the circulatory system from the alveoli of the lungs. The exchange of oxygen and carbon dioxide that occurs in the alveoli is called alveolar ventilation. The amount of air pulled into the lungs and removed from the lungs in 1 minute is called minute ventilation or minute ventilation. When a patient is not breathing, artificial ventilation is necessary to supply oxygen to the heart and the rest of the body. This is figure 7-3 from your textbook, and this shows what we were just discussing, which is the exchange of gases that occurs at the alveoli of the lungs. When we're talking about the pathology of the lungs consist of soft, spongy tissue that have no muscles. The movement of air into the lungs depends on the movement of the rib cage and the diaphragm. When the diaphragm contracts during inhalation, it flattens and moves downwards, drawing air into the lungs. On exhalation, the diaphragm relaxes and then the air is passed back out and it becomes dome-shaped again. So it flattens and moves downward to draw air into the lungs, and then it relaxes back into its relaxed dome shape, and that allows the chest to relax and the air to pass naturally back out of the lungs. This is figure 7-4 from your text, and it shows exactly the process that I just described. We talked about the ABCs of ventilation, which is airway, breathing, and circulation. And A is for airway. In healthy individuals, the airway automatically stays open. In an injured or seriously ill person, they may not be able to protect their airway, so it may become blocked. You must check the condition of a patient's airway and correct any problem you find to keep the patient alive. The first thing you always want to do with a patient is check for responsiveness. Determine whether the patient is responsive or unresponsive by asking, "Are you okay? Can you hear me?" If you get a response, you can assume that the patient is conscious or at least semi-conscious, and if they're able to respond, then they have an open airway. If there's no response, gently shake or just gently move their shoulders and repeat your questions and see if you can rouse some level of consciousness in them. If your patient is unresponsive, you need to call 911 before doing anything. If you are responding as part of a 911 call, then you need to call for more advanced assistance. Then carefully position the patient by supporting their head and neck and placing the patient on his or her back. Quickly scan the patient's chest for breathing, watching for rise or fall, and check for a pulse. If the patient has a pulse but is not breathing, you will need to correct the airway. So let's talk about correcting a blocked airway. If you recall, I mentioned earlier that an unconscious patient has no muscle tone. So often their airway is blocked because the tongue has dropped into the back of the throat and is obstructing the airway. Simply opening the airway may enable the patient to breathe spontaneously. And you open their airway by doing a head tilt, chin lift maneuver. Place the patient on his or her back, which we already mentioned, and kneel beside the patient. Your knees should be even with their shoulders. Place one hand on the patient's forehead and apply firm pressure backward with your palm. Don't press down on their skull, just using gentle pressure. Put pressure on their forehead and tilt their head back with the palm of your hand, and at the same time place the tips of your fingers with your other hand under the bony part of the lower jaw near the chin, and then lift the chin forward to help tilt the head back. So that's the head tilt, chin lift. Remember that the mandible is a hollow I mean, it's an edgy bone, meaning that if you press uh, too far back, you're pressing the tongue into the roof of the mouth, and you won't succeed in opening their airway. So make sure that your fingers are placed on the bony part of the mandible when doing the head tilt chin lift. Depending on the type of incident that occurred, or if you have reason to suspect that a person might have sustained a neck injury, then you need to correct or open their blocked airway by using a jaw thrust maneuver. Again, this is the technique to use if you suspect a neck injury. Having placed the patient on his or her back, you want to kneel at the top of the patient's head. This is for the jaw thrust maneuver. Place your fingers behind the angles of the patient's lower jaw, which is back by the just below the ears, and gently move the jaw forward with firm pressure. Because the unconscious patient has no muscle tone, there will not be any resistance. So you'll be able to slide their jaw forward, and this will help pull the the tongue out of the back of the throat. Tilt the head backward to a neutral or a slight sniffing position. In other words, you don't want to tilt it as far back as you would with a head neck chin lift maneuver. You just want to tilt the head backward just enough to bring it to a neutral or a slightly sniffing position. Use your thumbs to pull down the patient's lower jaw, opening the mouth enough to allow breathing through the mouth and nose. This is figure 7-7, which illustrates the maneuver I was just discussing, the jaw thrust maneuver. And this jaw thrust maneuver should open the patient's airway without extending the neck. You also want to check their oral airway or check their mouth for fluids, foreign bodies, or dentures. After you have opened their airway, you want to look into their mouth to see if anything is blocking the airway, anything visible, whether it be fluids, dentures, food, etc. These potential blocks include secretions of vomitus, mucus, or blood, foreign objects such as candy, food, or dirt, or dentures or false teeth. If you find anything that's very visible in the patient's mouth, then you need to remove it. If the patient's mouth is clear, consider using one of the devices described in the section on airway devices, which will be covered separately. You want to correct the airway using a finger sweep or suction. Vomitus, mucus, blood, and foreign objects must be cleared from the patient's airway. When using a finger sweep, this can be done quickly and requires no special equipment except, of course, the use of medical gloves. To perform a finger sweep, follow the steps that are outlined in Skill Drill 7-1 in your textbook. As far as suctioning is concerned, suction machines can be helpful in removing secretions such as vomitus, mucus, and blood from a patient's mouth. There are manual suction devices, and these devices are relatively inexpensive, are compact, and easy enough to fit into an EMR life support kit. Insert the end of the suction tip into the patient's mouth, not very far, uh, just just about into midway into the mouth, and squeeze or pump the hand-powered pump to help withdraw secretions, blood, or vomitus. Mechanical suction devices use either a battery-powered pump or an oxygen-powered aspirator to create a vacuum to withdraw secretions or blood or vomitus from the patient's mouth. Such a device draws the obstructed materials away from the patient's airway. Clear the patient's mouth of large pieces of material with your gloved finger. Turn before you use this device, and then turn on the suction device and use the rigid tip to remove most of the remaining material. Do not suction an adult for more than 15 seconds at a time, and for a child no more than 10 seconds, and for an infant no more than 5 seconds, because suction does also draw air out of the patient's airway. Change to a flexible tip and clear out material from the deeper parts of the patient's throat, if necessary. This is figure 7-9 from your book, and this is one type of a battery-powered suction device. They all look pretty similar no matter who manufactures them. Now let's talk about maintaining an airway. For unconscious patients, you must continue holding the patient's head to maintain the head tilt chin lift or jaw thrust position. If a patient is breathing adequately, you can keep their airway open by placing the patient in the recovery position. You can also insert an oral or nasal airway to keep the patient's airway open. I mentioned placing a patient into the recovery position, and you only want to do this if it involves an unconscious patient who is breathing and you do not suspect trauma to the head or neck or spine, in which case it's safe to place them in the recovery position. The recovery position helps keep the patient's airway open by allowing secretions to drain out of the mouth instead of draining into the trachea. For instance, people who are unconscious because their stomach is not functioning will very often vomit. So if they're in the recovery position, the vomit will drain from their mouth rather than them accidentally aspirating it or breathing it into their lungs, which is very dangerous. Also, the recovery position uses gravity to help keep the patient's tongue and lower jaw from blocking the airway. This is figure 7-12 from your text, and this illustrates the recovery position. When you place a patient in the recovery position, you want to roll the patient onto one side as you support the patient's head. Place the patient's face on his or her side so any secretions drain out of the mouth, as I discussed. And as you can see, you take the arm and place it underneath their head, so that helps keep their head in a more neutral position and off of the ground. I mentioned briefly earlier the use of airway adjuncts. Airway adjuncts are designed to help serve two primary purposes: to help maintain an airway and also functions as a pathway for suctioning. Oral airways can be used for unconscious patients who are breathing, who are in respiratory arrest, and do not have a gag reflex. In other words, if you try to insert an oral airway or an oral adjunct and they gag, they have an active gag reflex. So you can only use an airway adjunct on a person who does not have an active gag reflex. These airways can be used with mechanical breathing devices such as a pocket mask or a bag valve mask device, a BVM. There are two styles of oral airways. One style has an opening down the center which you see on the left side of the photo, and the other has a slot along each side, which you see on the right side of the photo. Before you insert an airway, you need to select the proper size. Choose the proper size by measuring from the earlobe to the corner of the patient's mouth. Follow the steps in Skill Drill 7-2 in your text to insert an oral airway. The other type of airway adjunct you heard me mention earlier is the nasal adjunct or nasal airway. This device is inserted into a patient's nose. Nasal airways can be used in both unconscious and conscious patients who are not able to maintain an open airway. Nasal airways are not as likely as oral airways to cause vomiting because they do not impact the potential active gag reflex. Also, these are recommended in patients who have trauma to the mouth. You cannot suction through a nasal airway, however. Be sure to select the proper nasal size airway for the patient. Measure from the earlobe to the tip of the patient's nose. You want to be sure to coat the airway with a water-soluble lubricant such as KY or Surgilube before inserting it. The airway is fully inserted when the flange or the trumpet rests against the patient's nostril. Follow the skills or the steps in Skill Drill 7-3 in your text to insert a nasal airway. We talked about the ABCs of respiration: airway, breathing, and circulation. And B is for breathing. After you have checked and corrected the patient's airway, you will next need to check and correct the patient's breathing. Signs of adequate breathing are to use the look, listen, and feel technique to assess if an unconscious patient is breathing adequately on their own. Look for the rise and fall of the patient's chest. Listen for the sounds of air passing into and out of the patient's nose or mouth, or feel the air moving on the side of your face. So you want to lay your cheek near the patient's nose and mouth and feel for airflow coming from their nose and mouth. Normal adults have a resting breathing rate of approximately 12 to 20 breaths per minute, so you want to give yourself adequate time to determine whether or not they are actively breathing. One breath includes both an inhalation and an exhalation. Signs of inadequate breathing include noisy respirations, wheezing, or gurgling, which indicate a partial blockage or constriction somewhere along the respiratory tract. Rapid or gasping respirations may indicate that a patient is not receiving an adequate amount of oxygen as a result of illness or injury, and the patient's skin may be pale or even blue. In other words, you'll see a blue tinge or a bluish gray tinge around their lips. The most critical sign of inadequate breathing is respiratory arrest, which is characterized by 3 signs: lack of chest movement, lack of breath sounds, and lack of air against the side of your face. Causes of respiratory arrest include heart attack, mechanical blockage or obstruction caused by the tongue, vomitus, particularly in a patient weakened by a condition such as a stroke, as one example, or foreign objects such as broken teeth, dentures, balloons, marbles, pieces of food, or hard candy, especially in small children, or illness or disease. Some other causes of respiratory arrest include drug overdose, poisoning, severe loss of blood, or electrocution by electrical current or lightning. You always want to check for the presence of breathing, and when doing so, your assessment of any motionless patient begins by checking for responsiveness, as we discussed earlier, and assessing for breathing. If a patient is responsive and not breathing, you need to assist him or her as needed. However, if a patient is completely unresponsive, you need to determine if the patient requires assistance with breathing or other interventions. While checking to see if a patient is responsive, look for signs of breathing by visualizing the patient's chest and observing for visible movement. You will have learned about rescue breathing from your American Heart Association certification on rescue breathing. And as you perform rescue breathing, you want to keep the patient's airway open by using the head tilt chin lift maneuver or the jaw thrust maneuver. Pinch the patient's nose with your thumb and forefinger, take a deep breath, and blow slowly into the patient's mouth for 1 second. Remove your mouth and allow patient's lungs to deflate. Breathe for a patient a second time. After these first 2 breaths, breathe once into a patient's mouth every 6 seconds. While mouth-to-mouth breathing is absolutely recommended, especially in absence of any other form of device, such as the ventilation device we see here in this picture, you do want to use at least a pocket mask. But a mouth-to-mask rescue breathing is much more efficient. It delivers a much more solid stream of air into the lungs. With mouth-to-mask rescue breathing, this enables you to perform rescue breathing without mouth-to-mouth contact with the patient. A mouth-to-mask ventilation device consists of 3 parts: a mask that fits over the patient's face, and it has a one-way valve so that when they exhale, you're not inhaling the breath that they exhale, and a mouthpiece through which the rescuer breathes. Because mouth-to-mask devices prevent direct contact between you and the patient, they reduce the risk of transmitting infectious diseases. To use a mouth-to-mask ventilation device for rescue breathing, you want to follow the steps in Skill Drill 7-4 and also what you learned from your certification from the American Heart Association. I mentioned pocket masks. These are also known as mouth-to-barrier rescue breathing. And when using this type of device or doing mouth-to-barrier rescue breathing, some of these devices are small enough to carry in your pocket, which is why they're called pocket breathing masks or pocket devices. Most of these devices consist of a port or hole that you breathe into and a mask or plastic film that covers the patient's face. These devices do provide a variable degree of infection control. Because they have that mask or plastic film, the patient exhales underneath that film so that you do minimize some of the interaction between your breath and the patient's breath. To perform mouth-to-barrier rescue breathing, you want to follow the steps in Skill Drill 7-5 in your text, and also what you learned from your American Heart certification. There are times when you'll have no device at all, but you have to provide rescue breathing for your patient, and that is straight mouth-to-mouth rescue breathing. This technique requires no equipment. There is somewhat higher risk of contracting a disease when using this method, but the odds are pretty minimal with the exception of the coronavirus pandemic, which we're going through at the moment as of this recording in 2021. But to follow these steps for correct rescue breathing using mouth to mouth, you want to follow these steps. Open the airway with a head tilt chin lift maneuver. Pinch the patient's nostrils together with your thumb and forefinger. Keep the patient's mouth open with the thumb, whichever hand you are using to lift the patient's chin. Take a deep breath and then make a tight seal by placing your mouth over the patient's mouth. breathe slowly into the patient's mouth for 1 second. Remove your mouth and allow the patient to exhale passively, and then repeat this rescue breathing sequence 10 to 12 times per minute for adults and 12 to 20 times per minute for infants and children. With infants, because the distance between their nose and upper lip and mouth is so small, you can provide mouth-to-mouth breathing in an infant by covering their nose and mouth with your mouth. Earlier, you heard me mention a bag mask device, also known as a bag valve mask device. And the bag mask device has 3 parts: a self-inflating bag, a one-way valve, and a face mask. To use this device, you want to place the mask over the face of the patient and make a tight seal. Squeezing the bag pushes air through a one-way valve through the mask and into the patient's mouth and nose. As the patient passively exhales, a second one-way valve near the mask releases air, so you're not inhaling their passive exhalation. Bag mask devices deliver 21% oxygen without supplemental oxygen attached. However, supplemental oxygen is usually added to the bag mask device. Many bag mask devices are designed to be discarded after a single use. This is figure 7-20 from your book, which illustrates using a bag mask device with 2 rescuers. A single rescuer may find it difficult to maintain an adequate seal between a patient's face and mask with one hand. So it is ideal for 2 rescuers to use a bag mask device. So the bag mask device technique is to follow the steps in skill drill 7-6 in your book. Use of a bag mask device is best accomplished, as I mentioned, as a 2-person operation if additional rescuers are present. So let's do an airway and breathing review. You should assume that all patients may be in respiratory arrest until you can assess them and determine whether they are breathing adequately on their own. With the airway, you should check for responsiveness by shouting, "Are you okay?" and gently shaking the patient's shoulder. The reason you want to shout is that semi-conscious patients don't hear very well. So by shouting, you're helping to stimulate their brain and encourage them to respond. If a patient is unresponsive and the EMS system has not been notified or more advanced rescuers have not been notified, then you want to absolutely do so. Place the patient on his or her back and correct a blocked airway by using the head tilt chin lift maneuver or jaw thrust maneuver. And just to remind you, again, this is a review. So we've talked about these things in detail. And I also indicated early in this the page you need to read in your textbook and also the skill drills you need to review in your textbook that are meant, or that this is meant to supplement. Continuing with the airway and breathing review, you want to check the mouth for any secretions, vomitus, or solid objects. If found, clear the mouth. Correct a blocked airway, if needed, by using finger sweeps, or suction to remove foreign substances. Maintain an airway by manually holding it open or using an oral or nasal airway or adjunct. And then you want to check for the presence of breathing while determining responsiveness. If there is none that you can determine, correct their lack of breathing by performing rescue breathing using a mouth-to-mask or mouth-to-barrier device if available. And then, of course, if there is not one available, then you must use mouth-to-mouth. Children are smaller and you will not need to use as much force to open their airways and tilt their heads. With rescue breathing for children, make sure that you realize that you need to not tilt their head back nearly as far. And the rate of rescue breathing is slightly faster for children. So you want to give one rescue breath every 2 to 3 seconds, which is about 20 to 30 rescue breaths per minute. Infants are extremely tiny and must be treated with very gentle maneuvers. Their airway is not structured and developed. It is simply like a tube, if you will. So if you hyperextend their neck, that tube will literally pinch shut. So you want to make sure that you only tilt their head back enough to allow air to go into their airway. Do not hyperextend their neck. The steps in rescue breathing for an infant are shown in Skill Drill 7-7 and are also covered in your American Heart certification. The first step in caring for a conscious person who may have an obstructed airway is to ask, "Are you choking?" If the patient can reply to your question, then their airway is not completely blocked. But if their patient is not able to speak or even cough, then their airway is completely blocked. And they will indicate this as a reflex by putting their hands toward their throat, which indicates that they aren't able to get any air. With mild airway obstruction, a patient will cough or gag, and the patient may even be able to speak, although they may do so with difficulty. If a patient has a mild airway obstruction, you want to encourage them to cough because that's the body's natural way of clearing a foreign object or liquid or anything that shouldn't be there out of the airway. But if the patient cannot expel an object, you need to arrange for prompt transport and also be aware of the fact that because they're not able to clear their airway adequately, they may lose consciousness. With severe airway obstruction, the patient is unable to breathe in or out because they cannot exhale air, so speech is impossible. So if you see someone who is conscious but is reaching towards their throat and is completely silent, they're indicating to you that their airway is obstructed. And there may be poor air exchange. In other words, they may be almost completely occluded, or they may be having an increased breathing difficulty. In other words, maybe they're able to get a little bit of air in and out, but they are reaching a point where they can not exchange air at all. Or they may have a silent cough where their body is racking, trying to cough, but it's called silent because there's no air exchange taking place. So the cough is completely ineffective. Anyone in this position is likely to lose consciousness within 3 to 4 minutes, but it can happen sooner than that. The currently accepted treatment for a conscious patient who has an obstructed airway or a nearly obstructed airway involves abdominal thrusts, also known as the Heimlich maneuver. Abdominal thrusts compress the air that remains in the lungs against whatever's in the airway, forcing the object or objects out. Now we're going to talk about management of foreign body airway obstructions. Relieving a foreign body airway obstruction requires no special equipment. If there's an airway obstruction in an adult and the patient is conscious, you want to stand behind the patient and perform abdominal thrusts while the patient is standing or seated in a chair. To assist a patient with a complete airway obstruction, you need to follow the steps in Skill Drill 7-8. Performing cardiopulmonary resuscitation or CPR on a patient who has become unresponsive has the same effect as performing the Heimlich maneuver on a conscious patient. When opening the airway of a child or infant, you need to tilt the head back just past the neutral position. If you are by yourself and a child with an airway obstruction becomes unresponsive, perform CPR for 5 cycles, roughly 2 minutes, before activating the EMS system or calling for more advanced assistance. If the airway obstruction is in an infant, their airway structures, again, are very small and are much more easily injured than those of an adult because they do not have the cartilage developed around their windpipe or airway. However, if an infant has an audible cry, then their airway is not completely obstructed. To clear an airway obstruction in an infant, you want to use a combination of back slaps and chest thrusts. To assist a conscious infant with severe airway obstruction, you must assess the infant's airway and breathing status. Place the infant in a face-down position over one arm so that you can deliver 5 back slaps. This will have been covered also in your American Heart certification. Turn the infant face up and deliver 5 chest thrusts in the middle of the sternum. Repeat the back slaps and chest thrusts until the foreign object is expelled or until the infant becomes unresponsive. If the infant becomes unresponsive, continue with the following steps. Assure that more advanced help has been called or the EMS system has been activated, and begin CPR and continue that CPR until more advanced EMS personnel arrive. Now we're going to discuss oxygen administration. Administering supplemental oxygen to a patient who is showing signs and symptoms of shock increases the amount of oxygen delivered to the cells of the body and often makes a positive difference in the patient's outcome. Oxygen equipment includes oxygen cylinders. Oxygen is compressed to 2,000 pounds per square inch, or PSI, and stored in portable cylinders. Portable oxygen cylinders are used by most EMS systems in either a D or E size. Size D cylinders hold roughly 340 liters of oxygen, and size E cylinders hold roughly 660 liters of oxygen. Oxygen cylinders must be marked with a green color, and the entire cylinder may be green, or there may be green striping on it, and it must be labeled as medical oxygen. Depending on the flow rate, each cylinder should last for at least 20 minutes, but may last for hours if the flow rate is as low as 1 to 2 liters per minute. Oxygen cylinders should always be used with a pressure regulator or flow meter. The regulator and flow meter are a single unit attached to the outlet of the oxygen cylinder. Once pressure has been reduced, you can adjust the flow meter to deliver oxygen at a rate of 2 to 15 liters per minute, depending on what is needed. There is a gasket between the cylinder and the pressure regulator or flow meter that ensures a tight seal and maintains high pressure inside the cylinder. Also included with oxygen equipment are nasal cannulas and face masks. These are devices that ensure that oxygen is delivered to the patient and is not lost into the general airspace of the area you're performing assistance in. Nasal cannulas are used to deliver medium concentrations of oxygen, roughly 24 to 44% oxygen. A face mask is placed over a patient's nose and mouth to deliver oxygen through the patient's mouth and nostrils, and that delivers a higher, more sustained amount of oxygen. And non-rebreathing masks are most commonly used by EMRs. And the difference between a face mask and a non-rebreathing mask is they look identical, except the non-rebreathing mask has an oxygen reservoir bag that is suspended below the face mask. Whenever you're dealing with oxygen, there are many important safety considerations. Oxygen actively supports combustion and can quickly turn a small spark or flame into a serious fire. All sparks, heat, flames, and oily substances must be kept away from oxygen equipment. Smoking is never safe around oxygen equipment. High pressure in an oxygen cylinder can cause an explosion if the cylinder is damaged. Oxygen cylinders should be kept inside sturdy carrying cases and should never be set upright. They should always be either in their proper carrying case or lying on their side and supported so they don't roll, so they don't fall over. Handle the cylinder carefully to guard against damage. When administering supplemental oxygen, you want to place the regulator or flow meter over the stem of the oxygen cylinder and line up the pins on the pin indexing system correctly. These are easily identifiable. Tighten the securing screw firmly by hand. Turn the cylinder valve 2 turns counterclockwise to allow oxygen from the cylinder to enter the regulator or flow meter. In the figure, you see a valve stem with pin index holes. You want to check the gauge on the pressure regulator or flow meter. To administer oxygen, you must adjust the flow meter to deliver the desired liter per minute flow of oxygen, which will be determined whether you're using a nasal cannula, a face mask, or a bag valve mask. And you want to make sure that oxygen flow begins before you place the face mask or nasal cannula onto the patient's face. A nasal cannula delivers low-flow oxygen at 1 to 6 liters per minute and in concentrations of 24 to 44% oxygen. You want to adjust the liter flow to 1 to 6 liters per minute on the flow meter and then make sure that oxygen is flowing before applying the cannula to the patient. I mentioned non-rebreathing masks earlier. This, you can see, has the reservoir bag that is below the actual face mask. And a non-rebreathing mask consists of connecting tubing, the reservoir bag, one-way valves, and the face mask or face piece. This is used to deliver a high flow of oxygen at 8 to 15 liters per minute, and it can deliver concentrations of oxygen as high as 90%. The non-rebreathing mask should be used for patients who require higher flows of oxygen, including those experiencing shortness of breath, severe chest pain, carbon monoxide poisoning, congestive heart failure, or signs and symptoms of shock. To use a non-rebreathing mask, adjust the oxygen flow on the flow meter to 8 to 15 liters per minute to inflate the reservoir bag before putting it on the patient. Adjust the straps to secure a snug fit, and adjust the liter flow to keep the bag at least partially inflated while the patient inhales. The bag should never be fully extended like a balloon, for instance. There are hazards of using supplemental oxygen. Supplemental oxygen must be used carefully so that you, your team, and the patient will all remain safe. We talked a lot earlier about proper placement and use of oxygen bottles and assembling the flow meter, etc. You will need additional classwork and practical training before you're ready to administer oxygen in emergency situations. We're going to talk now about pulse oximetry. Pulse oximetry is used to assess the amount of oxygen saturated in red blood cells. This is a machine that performs this function, and the pulse oximeter consists of a sensor probe and a monitor. To operate a pulse oximeter, turn on the monitor. Once you know the monitor is operating correctly, place the sensor probe over the patient's fingertip or, if necessary, their earlobe. The monitor should then display the percent of saturation of oxygen in the patient's blood. In a healthy patient, oxygen saturation should be between 94 and 100% when breathing room air. If a patient has difficulty breathing as a result of injury or a disease process, the percentage of oxygen saturation may be much lower than 90%. If a pulse oximeter cannot tell you what is wrong with a patient, but it can help you recognize that the patient is having a problem and determine whether your treatment is helping the patient. In other words, if you're having to provide supplemental oxygen, their pulse oximeter reading should go up. A pulse oximeter does have certain limitations. It will not give an accurate reading if a patient is wearing nail polish or if a patient's fingers are very dirty, in which case you may have to use it on the earlobe. If a patient is cold and the blood vessels in the fingertips or earlobes are constricted, the pulse oximeter reading will not be accurate. Patients who have lost a lot of blood will have inaccurate readings, and patients who have experienced carbon monoxide poisoning will have false readings. There is no machine that can replace a careful patient assessment, including a good medical history. So the pulse oximeter is a tool, not the means to an end. You will sometimes have to give rescue breathing for patients with stomas. A stoma is an opening at the front of the neck where a patient has had a laryngectomy and they no longer breathe oxygen through their nose and mouth, but rather through an opening in their neck. So you should always check every patient for the presence of a stoma. If you're providing rescue breathing for a patient with a stoma, these are people who have, again, had surgery that has removed part or all of their larynx. So their upper airway now has been rerouted through that opening or stoma or hole in their neck. Rescue breathing must be given through the stoma in a technique known as mouth-to-stoma breathing. If you locate a stoma, keep the patient's neck straight. Examine the stoma and clean away any mucus in it. You have to use mild suction to do so. If there's a breathing tube in an opening, make sure to be sure that it is clear. Place your mouth directly over the stoma and use the same procedure as in mouth-to-mouth breathing. If a patient's chest does not rise, seal the mouth and nose with one hand and then breathe through the stoma. A bag mask device or a pocket mask device can also be used to ventilate a patient with a stoma. One thing you have to be on the lookout for is gastric distension. This occurs when air is forced into the stomach instead of the lungs. This increases the chance that the patient will vomit. You need to breathe slowly into the patient's mouth, just enough to make the patient's chest rise. If you keep blowing after their lungs are full, the air is going to leak over the epiglottis and into the stomach, and they're going to have gastric distension, and it will eventually cause them to vomit. Remember also that the lungs of children and infants are much smaller and require smaller breaths during rescue breathing. So anytime you're doing rescue breathing, it's just enough to make the patient's chest rise. You're not trying to blow a car tire up, for example. It's just enough to make the lungs increase and fill with air. Just enough to make their chest rise. In terms of dental appliances, do not remove dental appliances that are firmly attached. They may help keep the patient's mouth full so you can make a better seal between the patient's mouth and your mouth or breathing device. Loose dental appliances such as partials or dentures may cause problems. Partial dentures may become dislodged during trauma while you're performing airway care and rescue breathing. Be sure to remove dentures and put them in a safe place. If you're having to provide airway management in a vehicle, for instance, if a patient is lying on the floor or seat of a car, apply a standard jaw thrust maneuver because there's a likelihood that there is trauma to the head or neck. Use the jaw thrust maneuver, of course, as I mentioned, if there's any possibility that the crash could have caused a head or spine injury. If a patient is in a sitting or a semi-reclining position, approach the patient from the side by leaning in through the window or across a front seat. You want to make sure to grasp the patient's head with both hands to provide stability to their head and neck. Put one hand under the patient's chin and the other hand on the back of the patient's head just above the neck. Maintain a slight upward pressure to support the head and cervical spine. This is figure 7-33, which demonstrates airway management for a patient in a vehicle. By reaching through a window or entering the vehicle and being in the seat next to the patient, this technique has several advantages. You do not have to enter an automobile, or you have to only partially enter the automobile. You also can easily monitor a patient's carotid pulse and breathing patterns by using your fingers. It helps stabilize the patient's cervical spine and opens the patient's airway. So let's summarize what we've covered in Chapter 7. The main purpose of the respiratory system is to provide oxygen and remove carbon dioxide from red blood cells as they pass through the lungs. The structures of the respiratory system in children and infants are smaller than corresponding structures in adults. Think of it this way. Children and infants are not mini adults. They are distinctly different physiologically from grown adults. As a consequence, the air passages of children and infants may be more easily blocked by secretions or by foreign objects because everything is much more small, it's much less developed, it's much more easily subject to trauma. When a patient experiences possible respiratory arrest, check for responsiveness, open the blocked airway using the head tilt chin lift or jaw thrust maneuver, check for fluids, solids, or dentures in the mouth, and correct the airway if needed using finger sweeps or suction. To continue our summary, you want to maintain an airway by continuing to manually hold the airway open by placing the patient in the recovery position or by inserting an oral or nasal airway. Check for breathing by looking, listening, and feeling for air movement, and correct any problems by using a mouth-to-mask or mouth-to-barrier device or using a bag mask device for rescue breathing. It is important to use correct sequence for adults, infants, and children. If an airway is obstructed in a conscious adult or a child, Kneel or stand behind the patient and perform the Heimlich maneuver. Give abdominal thrust until the obstruction is relieved or the patient becomes unconscious. If a patient becomes unconscious, perform chest compressions based on their status as an adult, infant, or child. Move to the head, open the airway, and look in the patient's mouth. Do not automatically perform a finger sweep, regardless of the patient's age, unless you can see the object easily. Attempt rescue breathing. If the airway is still obstructed, repeat chest compressions, visualization of the mouth, and ventilation attempts until the obstruction is relieved. To conclude our summary, administering supplemental oxygen to patients who show signs and symptoms of shock increases the amount of oxygen delivered to the cells of the body and often makes a positive difference in the patient's outcome. Patients who have experienced a heart attack or stroke, or patients who have chronic heart or lung disease may also benefit from receiving supplemental oxygen. Pulse oximetry is used to assess amounts of oxygen saturation in red blood cells. Let's do some review questions. Review question 1. After opening the airway of a patient who has a pulse but is unconscious, you should A. Perform a blind finger sweep, B. Immediately attempt to insert an oral airway, C. Check for secretions, foreign bodies, or dentures, or D. Perform CPR. The correct answer is, of course, C. You want to check for secretions, foreign bodies, or dentures. Review question 2. You should place a patient in the recovery position to A. Prevent the patient from going into respiratory arrest, B. Allow secretions to drain out of the mouth, C. Protect the patient's spine from injury, or D. Facilitate administration of supplemental oxygen. The correct answer is B. Allow secretions to drain out of the mouth. Our third and final review question is, pulse oximetry is used to A. Assess the amount of oxygen saturation in red blood cells, B. Provide supplemental oxygen to the patient, C. Assess how much oxygen the patient requires, or D. Eliminate carbon dioxide from the bloodstream. The correct answer is A. Assess the amount of oxygen saturation in red blood cells. Class, that's everything we have for Chapter 7. I encourage you to contact your instructor if you have any confusion or need clarification on anything that was covered in this chapter. Be sure to remember that this is a supplement to your textbook. So use it for the tool that it is. And thank you always for your time and attention, and we will meet again for Chapter 8.